And, you know, I have this wonderful resource that I can contact every night. If I come home with a difficult case, I ask them what they think, and I've got the best on the planet sort of helping me with all of that. And we're from all over the United States, and we do have 3 Canadians. So I'm also a member of the International Contact Dermatitis Group, which is sort of a member from every representative country. I'm actually going to be running a meeting in June in Ottawa. We'll bring both groups together. We'll have a series of lectures and live cases, so it's an honor to be in that group as well. So I'm going to do a brief review of the immunopathogenesis of allergic contact. Now, this is going to be a big snore for the allergists, but I felt it was important just to review it. In the early phase, the eczematous process is spongiotic, and then as time goes on, it becomes more hyperkeratotic and cracked and fissured, and the histopathology will reflect that. So it's non-specific. It isn't. There are many eczematous patterns. Not all of it is allergic contact dermatitis. The first step is sensitization, and that can take 7 to 21 days. The antigen penetrates the epidermis, binds to a protein, and then the antigen-presenting cell, which for years we thought was the Langerhans cell, but it is not. It's a dermal dendritic cell, and it carries the antigen to the regional lymph nodes, presents it to naive T cells. There's T cell expansion occurring, an increase of CCL27 expression, which hones T cell honing, is upregulated in contact derm. And then with the next phase, the challenge phase, the skin is re-exposed to the chemical, elicitation takes place, there's antigen recognition, and at that stage it's 8 to 120 hours. It's usually about 2 days. And then you're re-exposed. There's recruitment of these memory T cells, elicitation of those cytokines IL-2 and interferon gamma. And then you get that inflammatory phase with vasodilatation, mediator release, leukocyte recruitment, adhesion, transmigration, and dermatitis at the site of contact, but also at older sites where there may be resident memory T cells and a recall reaction. And then in the resolution phase, the macrophages move in and there's loss of antigen stimulation. Just want to show you what it physically looks like. On the Monday, we put on all these patches. We reinforce them. I do a lot of patches. I do the North American Standard, and then if it's a hairdresser, I'll do a hairdresser's tray or a mechanic's tray or a shoe tray or a textile tray, whatever the story might be. And then they come back at 48 hours. We outline them. We remove the patches. But it's not until 96 or 120 hours that I do the final reading. And then we score the various reactions, and then we look for relevance and interpreting. That's where the skill comes in. I keep a little map so I can keep track of all the placement of the allergens. So it takes all week to do this, and you're asking people just to sponge bath and no exercise. So it's a commitment. I want to tell you about the #1 allergen now on planet Earth next to nickel. It's called methylisothiazinlone. Originally, we saw it more in a combination methylisothiazinlone. This is causing an epidemic of reactions worldwide. Every week I have 10 cases. It is in most shampoos, conditioners, hair gels, wet wipes, soap, dish detergents, laundry detergents, water-based paint. It's taken over my life. And I mention it because it is highly relevant with all these itchy scalps, itchy bodies, eyelids, hand dermatitis. Because all those pump soaps, when you go to the bathroom, have methylisothiazinlone in them. And you can come in with fingertip dermatitis from cleaners and wet wipes. Certainly a lot of eyelid dermatitis, a lot of communication on social media about this allergen. We always find relevant sources.
Interesting Facebook group.
This little guy had to blow up from water-based paint that was aerosolized for even a couple of weeks after it occurred, because it's in a 90% of water-based paints. So that's an issue if you're strongly sensitized. One of the reasons there's so many allergic people is it used to be the combination MCI-MI, and then industry thought, oh, MCI was the problem, so they started using MI, methyl-isothiazolone, alone in a much higher concentration rather than 15 parts per million, over 100 parts per million, and that ended up sensitizing a large population that are out there now. And also mechanics with their Waterless hand cleansers, which they use 50 times a day. All of them have methyl-isothiazolone. I'd like to share with you, this is a good example of the process of elicitation and sensitization and elicitation. Max Sauter presented this, won an award, and published this at the ACDS meeting. This is a woman who went to her dentist to get her teeth varnished, and they used Isodan. And it was obviously at that point that she was exposed and sensitization started. She didn't react then. Then unwittingly, I find this really hard to read because of my glasses, but then that was August. And then in September, she wore a pair of Kotex U pads, mini pads. Now, the superabsorbent material in pads has an acrylate. All of them have acrylates. Acrylates, when they're cured or polymerized, are no longer allergenic. It's the monomer, the small molecule, that's the allergen. So what must have happened with this batch of pads, it wasn't fully cured. So she wore the pads. She got this allergic contact dermatitis in the genital area that spread to her body, autoeczematized. And then, so she was treated by her family doctor with a topical corticosteroid. Wasn't sure what it was at the time. Then unwittingly, she went back to the dentist to get her teeth varnished again, not knowing that was the problem, and had an explosive gingival dermatitis in her mouth. And then she had facial edema and eczematous changes, then widespread contact derm. She finally made her way down to me, and we patch tested her, and she came up to all dental acrylates across the board. And I could have captured this on my standard series because we have acrylates on the standard series, so this poor woman didn't need to be tortured so much, but she is very acrylic allergic. And so we call the company for Isodan and find out they are using hydroxyethyl methacrylate, which is in the Isodan. And we call the Kotex people, and they just said it's a polyacrylate, but it almost certainly was one of the ones that she is allergic to, and that's why she reacted to those pads. So if you go back, it was in September when she first got the Isodan done that she was sensitized. And then the elicitation reaction is when she used those pads that weren't fully cured. And then another elicitation reaction when she went back and got her teeth whitened again. And then finally it was worked out. So acrylates are in a lot of things. They're in printing inks. They're in, ladies, they're in all those shellac nails and acrylic gel nails. Those nails, I think, are bad things because we do see a lot of reactions to them. They're in adhesives and some tapes. They're in, in all aspects of dentistry, not just the cements, but the white composite fillings. And, yeah. Okay, so I just want to show you, Lynn Giroux had a similar case. This was a lady that came in. She was originally a nail lady. That's probably when she became sensitized. And then she had a rip-roaring reaction to poison cottonseed pads. And she reacted to her own pad. Now, only this batch of pads. So this batch of pads probably had an uncured acrylate in them. Because if it's polymerized and fully cured, it's not going to be antigenic. And actually, I called for some superabsorbent material from Kimberly Clark, and we tested it to that specifically, and she reacted. So occasionally you can see reactions from pads to acrylates. And just one more case that shows this whole interesting phenomena. Carly Kirshen presented this. This was a lady that already had her porcelain veneers in, and they were installed in 2007. And they were okay. And then she decided to become a nail lady. So she does her nails once, she does it a second time, and the third time she gets a rip-roaring allergic contact dermatitis around the nails. And then she comes in with her lips swollen and her gingiva really inflamed and fixed. So I'm thinking, okay, let's find out what was used. And something called Vitriumir was used, which contains hydroxyethyl methacrylate. So what I think has happened here is that it wasn't fully cured. So there's still some monomer left, to which she's now sensitized because of the nails. And she has some resident memory T cells there, so they light up. So Vitriumir, Variolink. And just to mention too, the other profession that we see acrylate allergy in is in dentists with fingertips, because they work with these vinyl gloves or nitrile gloves, which acrylates permeate right through, and the assistant, the technician, and the assistant and the dentist are mixing these adhesives that part A and part B before they're cured, so they're exposed to the monomer. Now I want to switch gears to talk about systemic allergic contact. In this case, this was due to Cobalt and Compositae. Just to review with you, systemic, this is when the first exposure is topical. The second exposure can be oral or parenteral. And then there is hematogenous allergic contact dermatitis. The reverse has also been reported. So this is a fellow in the middle of January, comes in with this eczematous dermatitis with a linear streaky pattern. It looks like a plant. I mean, I'd even think of poison ivy or some plant, because that linear streaky pattern is very suggestive. It's the middle of January, and he says he hasn't got a garden at all in his home, and he's not touching anything. So we find out he's drinking each night chamomile tea, which has chicory and chamomile in it. And when I patch test him, he's very allergic to a lot of Compositae. And Compositae are those plants, they often come around a central pedicle, you know, chamomile, calendula, oxeye daisy, dandelion, chrysanthemum, sunflowers. They're all Compositae. And they have a oleoresin in them, sesquicryptone lactone, to which he was very allergic. Anyway, so what was happening, he was drinking the tea every night and getting this recall reaction. So we cleared him up, told him to drink his tea, got the rash back in the exact same spot, so it was the tea. I'd like to talk now about, this is a very interesting case, and this is good for the internists and the ID people if you're here. This is a gentleman that came in, and he had this vesicular, part of the reason I'm just speaking off the cuff, I cannot read this, but that's all right, I know the slides. The writing's too small. But anyway, he had a group vesicular eruption on his neck, very herpetiform. But he was seen by his family first, and his granny said, oh, put on some ghee tin oil on that. That'll clean it up right away. And, well, it didn't. It got itchy, and it was vesicular and edematous and a spreading edge. Look at the active eczematous border, dramatic worsening. So then he ended up minimal improvement with the ghee tin oil. In fact, it was getting much worse. And then he went to his family doctor. He had some lymphadenopathy now. She gave him hydrocortisone and an oral antibiotic, and it kept spreading. And then he ended up getting IV antibiotics when he was seen in Emerge, and he kept getting worse. And someone said, maybe we can call dermatology. They may have something to offer. I don't know, a little dig there. And said, you know, this is an eczematous dermatitis. This is an allergic contact, and put him on oral steroids, and he got better. And then he made his way down to me for patch testing. And we found out that ghee tin oil has a lot of stuff in it, but he was very allergic to all kinds of relevant co-reacting and cross-reacting allergens. He's very allergic to his own ghee tin oil, peppermint, orange oil, rosin, propolis, oxidized limonene and linalool, and bacitracin. So let's just look at how this fits in. First of all, we know that ghee tin oil is supposed to be the cure-all for everything, headaches, arthralgias, rash, You got it. I mean, so the granny was just swearing by it. And if you look at the ingredients, it has all kinds of plants in there, natural things, which we know can certainly be antigenic. And specifically, it had peppermint. So peppermint oil is in a lot of toothpaste and candies and flavoring agents. We all are exposed to peppermint, and it contains a lot of essential oils have oxidized limonene and linalool in them, like peppermint, eucalyptus, tea tree, lavender, rosemary, but we do see it in peppermint oil. And then, and the orange oil also has limonene and linalool in it. And he was allergic to this whole group. Propolis is also, it's in bees, it can be a contaminant in beeswax. We know it comes from a poplar tree. When the bee is making its hive, includes it into the beeswax, and it can be a contaminant, and it actually can co-react with the peppermint. And then limonene is the ingredient that's in a lot of cosmetics. It's from orange rinds, and it can be an ingredient in many essential oils. And linalool, it comes from mint tree, the Limonaceae tree, and it also can be in many essential oils in the oxidized form. And rosin comes from the pine tree. It's in a lot of adhesives, and it's in a lot of cosmetics. We see it in all those lip balms, Burt's Bees lip balm and mascaras, etc. So he was reacting to all of these. And just to make matters worse, he had put on polysporin, probably at some point, which has bacitracin in it, and that also pays my rent. Bad product. I'm sure it's in all your houses. Don't use polysporin. Not good. Plastic surgeons, no polysporin. Okay, so this shows that a sort of a complex constellation of cross-reactions and co-reactions to a number of fragrance agents that are significant. Okay, I'd like to switch again. This is Jennifer Beaker, published this and presented it. This is a lady. Now this is rare. I want to suggest to you this case is rare, and I don't want all these referrals from orthopedic surgeons, but it can rarely happen. This woman had very bad osteoarthritis, and she was a large lady, and she just had bad disease at a fairly young age. And the orthopedic surgeon would prefer to use stainless steel because it is more durable than titanium. And so in this case, we know that historically she was very allergic to nickel and cobalt and palladium. She had reacted to her brace that had thiourea, a rubber allergen. So I thought I would do something, not that I do this very often, but I said, I'm going to take a little disc of titanium and a little disc of stainless steel. And stainless steel contains nickel, chrome, and cobalt. But it's the stainless steel that they use in prostheses is usually such high-grade steel that it's very unlikely for it to be released. And there's a greater chance of it to be released if you have a metal-on-metal implant, a screw and plate situation. But in any case, I implanted it, well, I didn't, the orthopedic surgeon did, just under the, in the subcutaneous on the thigh, and we left it there for 6 weeks. Now, nothing actually happened at the site, but then she had a recall reaction and dermatitis on her shins where she had fractured her tibia years before and had a screw and plate put in and with metal on metal, and that had been removed, but the rash came up there. He was still, so she had a recall reaction, and she had a recall reaction on her back, which I think probably was the site where nickel had been. So the orthopedic surgeon still wanted, I said, you know, he still wanted to go ahead and use the stainless steel in this woman, so he did. And in the post-op period, she started getting erythema and swelling and heat at the surgery site. This was treated as an infection. And then 1 month later, she came in with this persistent dermatitis at that site. To this day is still there. And again, she had another recall reaction on her shin where the plate had been. She was treated with a steroid. And then she went ahead and had the other knee done, and he used stainless steel again. And she came back in post-op with dermatitis at both sites. Now, she's walking, she's happy. We just sort of give her ointment all the time. She lives with it. But it is possible. So I think it's one of those rare situations where there is release of metal from the prosthesis, and you would have to have the following, and you have to have a strong positive reaction, persistent dermatitis at the site that just doesn't really go away despite lots of medical treatment. There's different alloys used, there's a whole bunch of them, but I just, for simplicity's sakes, they're stainless steel, nickel, chrome, cobalt, or cobalt, chrome, or titanium alloys. And it's more likely to be a problem if you have metal on metal, if you're a very strong reactor, and if you have that dermatitis that is persisting at the site. Okay. Now, I also, in that same vein about orthopedics, Michael Sawchuk presented this case and published it. This is about a fellow that had a triathlon total knee replacement. And when the orthopedic surgeons do this now, almost in all cases, in the cement, they'll use cements that have antibiotics in them. And the antibiotic is either going to be an aminoglycoside, usually tobramycin or gentamicin, more often tobramycin, or it'll have, the cement will have vancomycin. And the cement, by the way, is methyl methacrylate, but it's cured. So this gentleman is having all kinds of problems with his knee, adhesions and whatnot, and he went in and had arthroscopy and extensive lysis of adhesions. And that was in January 2014. And in the post-op period, about a month later, he started getting this urticoid, very pruritic, persistent rash at the site of his knee. And a biopsy was done, and he, I don't have the biopsy results, but I think it did show spongiotic eczematous changes. And so he was sent for patch testing. And at the time, I didn't have tobramycin to test to. I do now. But he had a little bit of, not a big reaction to gentamicin, framacetin, which are aminoglycosides, and neomycin also on the standard series. So they can cross-react. Where people become sensitized to these aminoglycosides is usually through eye drops, when they get Tobradex after their cataracts, or they get Garazone. So they get sensitized. Or in the United States, we have bacitracin in our first aid creams. We don't have Neosporin, but in the United States they have Neosporin, and it has bacitracin and neomycin, and they get sensitized. So I did call the company, and the Stryker total knee has chrome, nickel, aluminum, cobalt, and the bone cement had methyl methacrylate copolymer, and it had tobramycin. So the surgeon had to go back anyway, so he decided to clean out as much as he could the cement. He replaced it. He says, I got to put in some antibiotic. So he used the vancomycin containing antibiotic, and this is the gentleman now. A little better. He's definitely better. Okay? Now, this next case is kind of a bit of a titillating one. This was a fun case. Joe Dumais, who's now in Montreal, presented this case and published it. This is not my picture. I got this picture from the internet because I didn't have a picture of my active case. But this fellow came in to me and said, I'm allergic to my recliner sofa, my recliner. And every time I sit there watching the hockey game or the football game, and I put my arms on the side rails and I stretch out and I got my shorts on my feet, I get a horrible rash on my thighs and my forearms. And I said, yeah, I don't think it's your Chesterfield. Anyway, we'll test you. So I tested him, and you know, sure enough, he didn't really come up to anything, and he said, I think it's my sofa. And I said, well, okay, bring in a piece of your sofa, and we'll we'll wet it and we'll put it on. But at the same time, I was checking about furniture allergy, And also my friend Denny Sassville in Montreal told me that, well, there's an epidemic in Europe of reactions to couches and sofas that are coming from China. And they found out that the allergen is dimethyl fumarate. And that's a little, in those little sachets that they put in the back of the furniture as a anti-fungal agent. And it ended up being sort of seeping into the furniture and causing allergic contact dermatitis. So sure enough, I got a hold of some dimethyl fumarate from a chemical supply company, and I diluted it down, and I just about blew the back off my guy, and then he got itchy on his arms and his legs, and he wasn't very happy. I said, well, okay, but we figured out the problem. And I took a little bit of his couch, and you can see it's a little vesicular there. So then I found out that they had banned these couches and sofas in Europe, and the company, Carter Couches, Linkwise Furniture, shipped a lot of them over to Canada. So they were in the Brick and places like that. So I called Health Canada and I reported it. And at the same time, my colleagues in, Joel DeKoven in Toronto and Sandra Skotnicki, they were all starting to see cases. And then I haven't had a case for 5 years. So presumably they did something about this. But, be careful about on-sale furniture at the Brick. Okay, so conclusion. Dimethyl fumarate is a potent contact allergen. It's in the sachets of furniture, sometimes footwear boxes, or even in Spanish shoes, as Health Canada is investigating. And Milkers is in the U.S., so I don't think it made its way there. Vicky Tarasca, who is now in Winnipeg, wrote and published and won an award for this project. In a nutshell, we were seeing a lot of women mainly, coming in with explosive dermatitis, and I became convinced it was related to their clothing. And we ended up patch testing them. That's way too big a piece of material to test to, but anyway, on that day I did. And it did become Allergen of the Year. And so the bottom line is we found out that it was in about a third of them, or 25% of them, they were hair dye allergic people that went on to react to textile dyes. And we know that in clothing that is synthetic clothing, polyester, acetate, nylon, it's dyed with azo dyes. They're dyed with azo dyes, which are very similar to hair dye. They're all para-amino compounds. And a lot of those acetate liners and suits, tight-fitting exercise outfits that all have polyester acetate in them, a certain percentage of the population will react to them if they are allergic to these azotextile dyes. And in the same vein, another resident, Lauren LeBerge, I asked her to look back at some of our hair dye allergic people and see how frequently they were cross-reacting with other related para-amino compounds. So we know that hair dye, paraphenylene diamine, can cross-react with sulfa drugs, with benzocaine, a benzoic ester local anesthetic, black rubber, which is isopropyl paraphenylene diamine. In the old days, PABA, which was used in a lot of sunscreens, is still in lip balms, aminoazobenzene, which is a shoe dye, and some of the textile dye. So if you're a hair dye allergic and you stop dyeing your hair, it doesn't mean your problems will stop. You may have some problems with cross-reactivity. And so we looked at over 100 cases of hair dye allergic people. Most of them became sensitized because they were hairdressers or just dyed their hair. Some from those black henna tattoos. Those, temporary black henna tattoos are laced with paraphenylene diamine. They're banned now. Anyway, of that group, a quarter of the hair dye allergic people would go on and react to clothing dyes. So, and about 7% to benzocaine, 6% to sulfa drugs, and a smaller percent to black rubber. Okay, so am I okay? I have, this is a good case. I just wanted to show you this. This is a woman, for the internist, I think you might be interested in this. This is a woman with had ulcerative colitis, and she was very atopic and had fragile high-risk asthma. Now this is old slides because this is from over 20 years ago. And she gave a history. She came in and she would develop eczema on her face, neck, and upper body. And she said to me, it's after every time I go to the Merge for my asthma and they give me Solumedrol, Solucortiv, or Prednisone. And she says it starts about 24 hours after, but it peaks about 72 hours. But she would also give a history of going to the Emerge for her asthma, getting these steroids, and getting worse about 6 hours later, downgrading, being transferred to the ICU, and then being intubated on several occasions. And she would have, then she would always wake up, you know, at 72 hours, or starting at 48 to 72 hours with this rash. So she was sent to me, and I patch tested her, and she was negative, and I patch tested her to steroids, it was negative. And then I called my mentor friend Stores, and I said, what do you think is going on with this lady? She says, well, you should try intradermal testing her to steroids. It's not something I do. So I originally, I'm telling you, I'm being very humble here. I obviously did this not initially in the right way, but I did it in my clinic. I did have a crash cart. I had the pharmacist mix up just 1 milligram of Solumedrol, Solucortiv, and even crushed up prednisone and made it into a 1 milligram solution. I started with the Solumedrol, waited about 10 minutes, did a little 1 milligram intradermal, and then she started to get wheezy, short of breath, hives about 40 minutes. So I decided I would take her over to the Emerge. So I drove over to the Emerge, and she ended up staying there overnight, and she became very bronchospastic later, and they wheezy, and they treated her with Atrovent, Benadryl, Intol, discharged her, and she came back with this rash on her neck and face. And there were her positives. She developed the rash at the site of where I injected her. Now, Solumedrol and Solucortiv are the old Group A, but now it's Group 1, the new classification. And I thought, well, what about groups, the less allergenic group, dexamethasone? I thought she needs a steroid. So we brought her back, and we admitted her this time, and the respirologist was there, and the team, and she had an IV, and we did it again, this time with dexamethasone, just to find out if there is any steroid she could have. In 15 minutes, she got dermatographic, headache, tachycardia, and she had to also be treated with Intol, Atrovent, and she had acute respiratory distress. So, and then she was actually transferred, yes, with this one to the ICU. I haven't read these slides in a while. So the bottom line is, and then she came back with this widespread eczematous dermatitis at the site of the dexamethasone and also on her face. So she is a person that's demonstrating this broad continuum of immunological reactivity, type 1, immediate hypersensitivity, but also type 4. And she seems to be reacting to Group A, or Group 1 now, and Group 3, but also Group 2, because she reacted to her Pulmicort inhaler, which is budesonide, so that's Group 2. So we don't really have a steroid group for her. So that's a problem. There are other reports in the allergy literature. This is an old reference. I'm sure there's more than 30 now. And they always test to the vehicle. In this case, it was negative. And it's been the corticoid. There's the greatest risk is with the IV route. Most are okay with oral. And there's a link to aspirin sensitivity. Okay. I might, I just wanted to show you a case of chronic actinic dermatitis. There's some allergens that need light plus the allergen together to cause the reaction. And when we see this striking photo distribution where it's cut off at the V of the neck, dorsal hands, that's a true spared under the chin. That's a true photo distribution. And when you see these people, you know, you need to ask them about a drug history. You need to do light tests to determine their minimal erythema to UVA and UVB. They need a biopsy, and they need to be photo patch tested. And we do that. So when we do it in duplicate. We do 2 sets of allergens. One is irradiated with light, and one is not as a control. And before you irradiate with light, you have to determine what is their minimal erythema dose to UVA. It's UVA light that you use for the testing. So it's a big ordeal. Actually, Yuka has and I share a case of a very exquisitely photosensitive man that has photoallergic contact. And, you know, this impacts their life. He had to wear a special hat and have his windows blocked out in his car and special protective clothing, and he's on Imuran and steroids. And actually, he was taken down by the police here in Kingston because somebody outside Kingston, someone thought that he was a terrorist, and he was strapped to the ground and handcuffed. And, you know, she actually wrote a paper on that. Yeah, you'll talk about it. It's kind of, I don't know if I got the whole details, but it was a pretty dramatic case. So with this, this gentleman, he was very similar to Yuka's case. He was photo patch tested, and he was allergic on the regular series without light to fragrance and actually to Compositae plants, which are linked to this disorder. But he had a photo contact allergy to his actual sunscreen agents. So the things that are being used to treat him were actually making him worse. And so he was allergic to Compositae plants, which are linked to photoallergy, and they become airborne. They land on the skin in combination with light or can cause a photoallergic contact. He also is sensitive to light alone. And then he put on his sunscreen, and that was also a part of his problem. He had a photoallergic contact to the sunscreen and just a plain contact to the Compositae. Here's a Swiss farmer with the same problem. I won't go through it in detail, but you have to patch test these people and photo patch test them. They're complicated to work out. They're very difficult to manage. We usually use Imuran in them, and steroids, thalidomide, photoprotective clothing. I've actually started to use dupilumab, and with some success. This is, Michelle Ramin presented this interesting case. This was a fellow that had this recurrent red-brown annular plaque on his penis, kept coming back at the same site. So that's characteristic of a fixed drug eruption. But his wife was very upset with him, thinking that he had been doing something he shouldn't be doing. And he really wanted clarification why this rash was coming back on his penis, because fungal cultures were negative, and it looked to me like a fixed drug, and it often is in the mouth on the penis. So he was having this domestic issue. So we actually patch tested him and was very allergic to Propolis. So Propolis is that from the poplar tree that can contaminate beeswax. And I thought, now how is that relevant? So, well, I found out that every morning he was putting bee pollen on his cereal to invigorate himself. So what we did is we cleared them all up, and then I said, try that bee pollen on your cereal. We re-challenged him. And first of all, before I go there, there's all kinds of names for Propolis. And there's been cases of type 1 and type 4 allergy, but no cases reported of fixed drug eruption. And just to recall that fixed drug eruption is this recurrent red-bound annular indurated plaque, often can be multiple or single, and it can last, you have an exposure to the antigen. It can come out within 30 minutes to 16 hours. It often heals with hyperpigmentation. Drugs can cause it, certainly tetracycline, NSAIDs, sulfonamides, antihistamines, barbiturates, but foods too. Quinine, cheese crisps, strawberries, tartrazine, and now Propolis. And patch testing isn't very helpful. Half the time it's negative. Prick testing isn't very helpful, or probably the most helpful thing is re-challenge. So that's what we did. And it came back. And the biopsy actually showed fixed drug eruption. Okay. And are you still okay? A little bit? Okay. We do use patch testing for certain drug reactions. It's not helpful for just the routine drug hypersensitivity reactions. I don't find it helpful for DRESS too much, or for erythema multiforme, Stevens-Johnson, but it is helpful for something called AGEP, acute generalized xanthomosis pustulosa, because that's a type 4 reaction, and about 80% of the time we can find the antigen when we use it for AGEP. So this is a woman who had a history of psoriasis. She complained of pruritus, so she was given hydroxyzine. And then about a week after, she developed this pustular eruption. She had fever, chills, high white count. Biopsy showed AGEP. And the differential is always, it can look very similar to pustular psoriasis. And it was confusing with her because she had psoriasis. So the question is it pustular psoriasis or AGEP? And you really kind of want to know, because giving steroids to pustular psoriasis can really make it much worse. But we would determine that it was AGEP, and we did the patch testing after the fact, months later, and she actually did get better with steroids, and she came back, and this is her biopsy site to hydroxyzine, which is caused the AGEP, and I biopsied the patch test site, and it showed AGEP. And here's another case. This fellow went to the dentist, and they often give you that benzocaine spray before they go ahead with their anesthetic. And then the next day, he came out with this pustular eruption. So he was already sensitized. And the biopsy showed the spongiotic subcorneal pustular dermatosis with these intraepidermal neutrophilic pustules, or AGEP. And so we treated him with steroids. He was really quite sick. He can have systemic involvement. And then he subsequently was patch tested, and we found out it was benzocaine. I've actually had about 3 to benzocaine. So AGEP is a type 4 reaction. It can appear 7 to 10 days after initial exposure, but once sensitized, it could be 12 to 48 hours. And so that's important. And I find it successful, a worthwhile thing to do in this particular drug reaction. Now this one is very interesting. I'm almost done. There's 2 really good ones at the end. This is a woman who came in with what we call STRIFE, symmetrical drug-related intertriginous and flexural xanthum. It's the old baboon syndrome, where you have predominance of the rash in the inguinal, axillary, buttock area. And so the question is, what was causing it? Well, it turns out that she, a week before, had a mercury thermometer that she broke. It landed on her thigh. She was cleaning it up. She remembers getting a bitter taste in her mouth, so she brought her hands to her mouth and ingested some mercury. And so it was a primary sensitization because it happened about 7 to 10 days later, according to her. And so I brought her back. I tested her to mercury, and she's positive. So it was very. And just to end, this is kind of another interesting one. The difference between toxicity and allergy is allergy, it's unique to that individual. It's a type 4 reaction. Toxic reactions can happen to anybody. They're universal, just if you meet the threshold to elicit the response. So this fellow came in, 47-year-old gentleman with this flagellate dermatitis, like he had been whipped. And it came on about 12 hours after consuming this homemade soup that he made with shiitake mushrooms. So it's this very characteristic, you think it's going to be factitious or, you think a lot of things when you see that. But so some of the things you should think of is, this is a guy who have dermatomyositis, can present like that, Still's disease, bleomycin, and eating half-cooked or raw shiitake mushrooms. So I walked into the room, I said, have you been eating shiitake mushrooms? And he says, yeah, I've been eating my homemade shiitake mushroom soup. So that was a nice call. And this can happen in this particular group, and it's a toxic irritant reaction to the limonene, which is a polysaccharide toxin. So heat deactivates it. And we see that, I guess it's seen quite a bit in Japan. And last night I was eating shiitake mushrooms. So we'll see what happens. But nothing's happened so far. But they were cooked. Yeah. Thank you.
Thank you, Melanie, for a wonderful whirlwind tour of kinds of contact reactions, and I'm glad we have lots of time for questions.
Yes. I have a question. So when you're writing up the case with the resident,
yes.
Is it usually the resident that comes and says, oh, Dr. Pratt, I really want to write up this case, or is it you that says, I think you should write up this case and talk together?
How's it go? Well, in our residency program, everybody's expected to do a project or a paper or a small study and publish it. It's part of and everybody does. A lot of them look to me to do that. So, and they also get to present at the ACDS at the Residence Forum. And I didn't show this slide. I blocked it. I had about 10 more slides showing all the awards and presentations that they have won. They get money, they get some recognition, they meet their requirements. So they're all very keen. And to be honest with you, it's usually who's involved in the case, who happen to be in the room with me. Now, if it's a senior resident and they're studying, I don't ask those guys. They're too busy. I mean, so it's usually along the way. And I'm approached because they want to get it out of the way, actually, I think. So I'll look for something for them. And then there's all the medical students. You know, they all want to get into derm, and they're eager beavers. But I feel my obligation is to the residents first. I mean, some of these are medical students too, but if they happen to be in the room with the case. But my obligation is to my residents, of which there are now, can be 17. I mean, you know, yeah.
Yes.
Yes.
There were a number of times where you mentioned biopsy when or where is that?
A biopsy? Well, that's a good question. Well, I mean, I don't have any problem recognizing eczematous disease, but we see people with combination of diseases. Eczematized psoriasis sometimes. Sometimes it isn't always black and white in medicine. You have a well-known psoriatic, but they come in with this superimposed eczematized reaction, and you want a clarification. What's going on here? Is this all psoriasis? I mean, is there a component of eczema? Or in the reverse, psoriasiform eczema. So sometimes we do it for clarification that way. There are some diseases that can have an eczematous or psoriasiform appearance. Dermatomyositis, subacute cutaneous lupus, if you're not, you want clarification about that. Those photoallergic contact patients, they should be biopsied because there can be different patterns with that. And the chronic ones, they can almost look pseudolymphomatoid. It used to be called actinic reticuloid. And I just want to see if it is, I mean, basically eczema is spongiotic. So I want to see what the pattern is. Sometimes differentiating between drug reaction and an eczematous process with, for instance, with the AGEP reaction, you know, that drug reaction I showed, acute generalized xanthomatous pustulosa. Well, I mentioned that can look like pustular psoriasis. So we want to make the differentiation. Actually, the histology is very close. You have to use your clinical acumen there too. Lots of, you know, I think you have to have training in derm to understand the nuances of the times that you would need to do that, but not routine. I mean, I don't biopsy a routine atopic coming in, but atopic derm. You realize there's many types of eczema. It's not just one type. So I'm talking to you today about allergic contact eczema, but there are other types of eczema. Atopic eczema, we have nummular eczema, you know, irritant contact, toxic eczematous reactions. So sometimes you need clarification. Does that answer?
Any other questions?
That steroid case, I didn't want to show it to the allergist because I thought, oh, they're going to ask me if I did controls and everything, and I didn't. It was very bush league, but you know, but that was a good case. I've never seen one since.
Yeah.
Have you?
I see steroid allergy quite frequently.
No,
actually.
type 1 though.
Yep.
Type
yeah,
1.
I do.
Oh,
yeah, with
okay.
positive intradermal tests,
Yes,
but
right.
I do serial dilutions.
Yes, I know. I'm sure you do.
So that you just get the local.
So I want to say that's not how to do it, but I just.
All right. Well, the Department of Medicine always has a little gift
Thank you.
literature
Lovely.
for our visiting speakers. So hopefully that's one that will
Yes.
go on your bookshelf.
Yeah,
And,
thank you.
Thank you so very much for a wonderful presentation. Please join me in thanking Dr. Pratt.
Thank you.